Will we be seeing both of us together in one screen, or what is it?
Yes, sir. Both together in one screen.
Yeah, I can see only you. Myself.
Huh? Yeah, I can see only Parimal. I can't see myself.
Sir, audience will see both of you.
You can see the small picture of mine, no, Naresh?
We are live. I could see only you. Now I can see only me.
The same.
Me with me.
I can see you in the small picture below.
So we are live.
Sure.
Good evening. For all those who have listening in to this 24/7 NASH platform, which is an educational platform to disseminate knowledge and facts on this vexing problem which affects so many of us in our community. NASH stands for non-alcoholic steatohepatitis. And to go through some of the vexing issues and address some of your questions, we are two of us, two gastroenterologists. I am Naresh Bhatt from Aster CMI Hospital in Bangalore. And I have with me a dear friend and colleague, Dr. Parimal Nawate from Pune, who's at the Jahangir Hospital there. And Parimal brings with him about 30 plus years of clinical practice. And I think I look old enough to have the same. Good evening, Parimal.
Good evening. Good evening. Pleasure to be with you.
We have a lot of patients who come to our outpatients with ultrasound reports saying that the report says there's something wrong with your liver. It says a fatty liver. And over these last few decades, we have realized that we can no longer ignore this finding and that it has certain implications, which we now know as non-alcoholic fatty liver disease, or in a more advanced stage is called NASH or non-alcoholic steatohepatitis. At the very onset, it needs to be made clear that the first two alphabets stand for non-alcoholic, which means that these people who suffer from this problem don't necessarily take significant amounts of alcohol or may actually take no alcohol at all and yet suffer from liver disease at some stage in their life. We have also come to sadly realize that it's not alcoholic liver disease, it's not hepatitis B, it's not hepatitis C, which are the major players in liver disease today, but NASH is now the topmost cause of liver disease, not only in India, but in many parts of the world. With this introduction, let me ask Parimal, you've been in practice for so long. Do patients with NASH form a significant part of your practice?
I think if you look at the patients with liver disease whom we treat in practice, they do form a very big part of our practice, and a lot of people with non-alcoholic fatty liver disease do come to us with various problems. They might not always be very bad problems. They might be just like you said, an ultrasound report which says that you have a fatty liver. And because they have read on the net or something like that, they are a little worried and then they come to us. And overall, I think if you look at adult population in India, 1 in 4, if I'm not mistaken, would be having the non-alcoholic fatty liver disease. If I say that, would it be correct?
Yes, maybe 25 to 30%. And this is across the globe. In many parts of the world, the number is quite staggering. So we have many patients with fatty liver disease. So that brings me to the next question. If I have a fatty liver, do I need to be worried or can I just take it easy?
Yeah, this actually, if you ask me, this is a very wide question. So the first thing I would say is really no cause for immediate concern. That I think probably is a very important fact which we need to tell patients. The second is fatty liver many times is not a single isolated abnormality. So a lot of these patients will have like hypertension, they might have increased triglycerides, they'll have increased cholesterol, they will have some history of heart disease. And most importantly, I think a lot of them will be overweight or obese. So you look at a patient with this report of non-alcoholic fatty or a fatty liver on ultrasound as a whole, and then see what all beyond the fatty liver he has, and then you can really answer these questions. So I think you would also agree that a lot of these patients are at least overweight, if not all of them are obese. A lot of them do tend to be overweight.
So what you rightly pointed out is that when we see a patient with just a fatty liver, we need to look at him holistically, because the risk there may be actually a little small, but his overwhelming risks may be in a different organ like the heart and other cardiovascular disease and thing. Which brings me to really the next question. Is fatty liver a sinister problem? And if so, what kills these patients? Why do they need to get worried?
This again is a little complex to answer, but in simple terms, I think what I would say is by itself, it is not sinister, but you can tell the patient that this is your first warning bell. So if somebody comes to you saying that his ultrasound has shown fatty liver, then you can tell them that this could be your first warning bell. And then you have to check on your lifestyle. You have to check on all these what are called as comorbidities like hypertension and so on. Very often, in fact, it is interesting to note that many of these patients in the long run may not die because of their liver disease, but they may die because of cardiovascular and heart-related problems. So like you also pointed out, I think we have to emphasize that it is not a single organ involvement, but it is a multi-system disease by itself. So this is something which we try and impress on the patient's minds so that they become aware that they have to take it as a warning signal. It is not an immediate, it is not like you have reached a point where some car is going to come and dash on you and next moment you're gone. But there's a long way to go till you reach that end, I think. So there's a long window of opportunity where you can do various things to prevent all these things which are likely to happen in the future.
So the important point is that even in a patient with a fatty liver, the first two causes of death are actually cardiovascular. That means heart attacks and strokes and cancer. And maybe liver disease would be the third. Have I got that right, Parimal?
Yeah, Naresh. But what happens many times is patients tend to read on the net. And on Google, when they read about non-alcoholic fatty liver disease, it is written, it is a commonest cause for liver transplant. It's a commonest cause for cirrhosis. It is a commonest cause for so many other things. So actually, most patients have really not reached that stage. If you look at a population who is getting transplanted, NASH may be a common cause, but not many patients from NASH group will eventually get transplanted.
Okay, so actually coming to focusing on the liver as such in NASH, we know that it could be sinister. And we do know that it can progress to cirrhosis and, of course, lead on to liver cancer. I mean, that's the most extreme situation. So could you bring about what are these stages or different stages in non-alcoholic fatty liver disease, and what is the kind of time frame that these can evolve?
So I think, like you rightly said, this question pertains mainly to the liver. So we will not talk here about comorbidities. So if you look at the liver, initially what happens is there is more fat which is accumulated in the liver. So either it is generated by the liver itself or the patient's diet and various other factors. They lead to increased fat accumulation in the liver. And that is what is picked up on an ultrasound as a fatty liver. And like you said, right in the beginning, we are talking about non-alcoholic fatty liver disease. So we take into consideration that these patients are not taking alcohol. So the first step is there is increased accumulation of fat in the liver. Now what happens is this fat itself can slowly damage the liver by various mechanisms which we won't go into. But these fats which accumulate in the liver actually trigger kind of inflammatory response, or our immune system starts recognizing that there's something wrong in this liver. There's some abnormal kind of accumulation. And it starts doing a very slow attack on the liver. And when this process goes on and on and on, then there's something which is called as fibrosis, or a scar tissue, which may develop in some of these patients. And the liver may eventually become slowly harder and harder. And then eventually you can have significant damage in the liver, which we can call as cirrhosis. So actually, if you ask me, there are a lot of these patients who come with a fibroscan report. And that is basically what tells you how stiff the liver has become. So do you usually recommend this fibroscan in all your patients? Or what does a fibroscan mean to patients?
Yeah, see, you're right that, see, we have a stage where the only fat, they then progress on to fat with inflammation of the liver, which means swelling of the liver cells and damage, then leads to scarring in the liver, which becomes fibrosis. And this fibrosis can progress ultimately to what we call cirrhosis. So as a question that you have rightly asked is the role of fibroscan and things like that. But I think much before fibroscan, I think we have many more issues to resolve. And to me, when someone comes with a fatty liver, or I suspect a fatty liver in someone, when I examine him and I find the liver is enlarged, or he comes to me with a report saying my liver tests are abnormal, or so on. I mean, there may be different scenarios. So to me, the first thing that I would like to deal with is, what is this liver disease due to? Now, for example, he may be taking enough alcohol to cause liver disease. That may be an area where we would like to intervene. Maybe he's got a viral disease like hepatitis B or C, which we may want to evaluate and treat, and they're all treatable. He may be having other metabolic conditions causing liver disease. We'll not go into that. But yes, finally, we come back to fatty liver, which we think if you have diagnosed. To me, what I would do is first exclude whether he's got diabetes. And to me, diabetes is one of the major causes of fatty liver in our practice. Two, I'd also see whether he's got a thyroid disorder. A low functioning thyroid or hypothyroidism can again result in a fatty liver. And both these conditions are eminently treatable. And three is, I would see whether he is actually obese. And obese just doesn't mean what's his weight. We see something called a BMI, which is a kind of indicator of his weight, but also to see whether he's got excessive body fat around the waist. He's actually measuring his waist or his girth. Now, these are things that are more important, to assess these patients. And if he's got diabetes or a thyroid problem, or maybe increased cholesterol or triglycerides, my focus there would be to sort of intervene here and manage those. Only when we have finished that, then I sort of try and focus on what is happening to the liver. If he's got a fatty liver, is it there only fat? Is there fat with inflammation? To me, these are important because these are entirely reversible.
Yesterday, I saw two patients in the outpatient clinic, and they had gone to the wellness center and they had, all those tests which were done. And they had increase in what is called as SGPT or ALT and SGOT or AST. And they really asked me, they were really worried because they obviously, a lot of these people keep on reading on the net. And there, suppose you assume that the normal value of these tests is around 40. Their value was, say, somewhere around 76 or 80. And they came to me saying that this is the report. So what do we tell these patients?
Yes. See, what happens, your SGOT or SGPT actually reflect to a large extent that these cells are getting destroyed. I'm not trying to sound alarmist, but this is exactly what it is. So if you find that these cells are getting destroyed, it is important for us to find out why. Why are they getting destroyed? And if so, if I know the cause, can I prevent it? That is a very simple way that we look at it. And so if your SGOT, SGPT is elevated, I would tell the patient, yes, there's something cooking in your liver. Let's try and find out what it is. And certainly, NAFLD or non-alcoholic steatohepatitis is an important cause for this. There are other causes, but I don't think that's the focus today.
Sure.
The question that you
were
asking,
have a patient who is having both an ultrasound report showing a fatty liver and raised transaminases, do both of these work even worse for a patient than a single abnormal report?
Of course. Of course, more. See, suppose you put many things. You say he's got a fatty liver on ultrasound. His liver tests are abnormal. And to it, you add that he is obese. He's fat. He's got a big girth. You add diabetes to it. You add family history to it. And that becomes a fairly, dangerous kind of combination. If you don't have those, just one of them, I mean, it's still possible, but the probability would be much less. The more factors that you sort of put into the pot, I think what you'll come out is more serious probability of
it becomes more kind of inflammable material.
Absolutely.
So you said something about family history. So a lot of patients do ask, and I think I can see some questions here as well, that somebody's dad unfortunately had fatty liver disease and some problems. So is it really genetic in the true sense, or how do we answer these questions?
Well, it could be both. See, for example, a lot of things run in families, they are not necessarily genetic. For example, you're eating perhaps the same kind of food that your father did, right? Certain habits tend to be in the family. The father is sitting in front of the TV and eating a lot of junk food. The son is going to do the same thing. So there would be those factors which would be common. But yes, there are genetic factors which can be responsible for this. And we know of certain genetic disorders, mutations, which can sort of push someone towards this disorder. But unfortunately, genetics is not what we can change. We got to live with those genes. But yes, we can make amendments with some changes in our own lives, I think, which maybe we can discuss. I think going back to your FibroScan, so in a simple language, if someone says that my FibroScan is showing an increasingly stiff liver, it was something last year or 2 years back, and now it is more stiff, what does it mean?
Normally what we do is, there are various ways in which you can investigate these patients with fatty liver. Like you discussed earlier, we can do an ultrasonography. You can do the liver function test. You can do tests to make sure that there are no other causes which are presenting with these abnormalities. Once you have done that, and once I think I have established that this patient has a non-alcoholic fatty liver disease, I think we try to find out whether his liver is getting stiffer and stiffer. Because in very simple terms, I think the stiffer the liver and more the comorbidities like diabetes and everything, the chance of that patient's progressing to cirrhosis becomes higher. It is not 100%. It becomes higher, and the trajectory may become a little faster. So if somebody without all these problems, he may kind of progress a little slowly. But if he has all these factors with a FibroScan which shows their liver is becoming pretty stiff, then I think these patients tend to, we have to be very careful. The patient has to be very careful. And then you have to change the treatment strategies for these patients.
I would like to add one more dimension to this.
This is actually an important thing. I would again say is this is a non-invasive test. So it is almost like an ultrasound. Only thing is it is more expensive. Would you agree with that?
Oh, yeah, certainly. In fact, a lot of people are asking what's the cost. And I think in Pune, it's a little more expensive than what happens in Bangalore, but I think it will cost several thousands thing. But it's a good test, but expensive. It can be easily repeated. I mean, theoretically, of course, it costs big money, but I think at some stage, it may be a good idea to get that value for us to predict. See, the other dimension that I want to put is that if you have a very stiff liver or what we call a lot of fibrosis, it also impacts two things. One is that we know that we are already lost that big window of opportunity because simple fat to inflammation to fibrosis, that process has already taken over maybe 10, 15 years or more.
Very, very true, very true.
So it's a long process. And once we come to that stage of increased fibrosis, now we are closer to a more sort of severe kind of liver disease, though there are stages even in fibrosis. The other thing that's important, why Parimal and me would like to know why there's fibrosis, is how to choose your treatment. Because all medicines, all drugs may not work well when there is fibrosis, and we would ideally like to treat it before there is too much of fibrosis. So fibroscan, though it's expensive, is sometimes useful and in helping us predict as to how to go. Because this is the only other way other than doing a liver biopsy. Parimal, do you do a lot of liver biopsies in your practice? And what's your take?
Liver biopsy, actually, we hardly do these liver biopsies nowadays because we have fibroscan, which is almost like a substitute for a liver biopsy. And see, the reason behind doing liver biopsies is to find out the exact position of the liver under the microscope. So you are actually taking a thin piece of the liver with the use of a biopsy needle, putting it under the microscope and looking for various things which we won't go into details, but some of them I would like to highlight here. One thing is the hepatocytes or the liver cells, they become enlarged, and they become enlarged with a droplet of fat inside. So that is how we identify fatty liver. And then, like I said in the very beginning, there are a lot of these inflammatory cells which try and identify these cells as abnormal. And then they try and accumulate there and try to destroy these cells for various reasons. And then when they get destroyed, then there can be laying down of this fibrous tissue and so on. So basically, we used to do all this to know how much is the fat in the liver, how much is the damage, how much is the fibrosis. But now what happens is with the ultrasound, you can say that there is a grading in ultrasound as well as to grade 1, 2 and whatever. So the ultrasound also tells you that there's a fatty liver. The fibroscan tells you how much is the fibrosis. So we really don't need to do a liver biopsy today, at least in 2020. We do it for a very selected group of patients. Maybe suppose you have a patient who has F3 or F4 fibrosis. And if you want to know if there's some alternative cause for his liver disease, we may do a liver biopsy. But per se, it is not really going to change your diagnosis of non-alcoholic fatty liver disease. The staging also you can do by non-invasive means today, which is very good for patients actually. So they don't have to go.
So Parimal, what is this MR spectroscopy? I mean, do you believe in that is to tell us how much fat, or is it really for research purposes? Should a patient really
a lot of these tests, actually, you have to remember, a lot of these tests came as research tools. Even fibroscan, we were attending liver meetings within India together. We used to hear lectures and we used to be participants in various forums where it was a research tool. But today it has become a day-to-day tool which you can use in practice. So the same holds for MR elastography. It is a far more accurate method of determining the status of fatty liver disease. Because two things. One is, if you look at the fibroscan, there is a new modification of it, but by and large, the fibroscan mainly tells us about the amount of fibrosis or stiffness in the liver, but not much about how much fat is there in the liver. So if you do a MR elastography, that's a very, very useful method, but the cost is many, many, many more times as compared to. So it is, to me, I think it's a good test, but today I think it's not a very practical test to decide what is to be done with an individual patient. Would you agree with that, or what is your feeling?
Absolutely. Absolutely. Liver biopsy, again, in exceptional circumstances, when you're not sure whether there may be more than one cause for the liver disease, fatty liver and something else, and you want to decide how you're going to treat them, I think I would do a liver biopsy. We do maybe 15 a year, not more than that. So it's, by and large an exception rather than the rule. Now, having decided that this patient's got fatty liver, we do tests to find out what stage it is, and then we counsel. And ultimately, when we counsel, what are your first 3 modalities of therapy?
Modalities of treatment, I think there are 3. Like you rightly said, you pointed out 3, and there are 3 in fact. The first is lifestyle modification. So the aims of doing this is mainly to lose weight, lose your fat, control comorbidities like diabetes. By doing all this, also control your cardiovascular risk related to the diet. The second thing you do is to give medicines to improve the status of the liver itself. And most importantly, the third thing is we look at comorbidities, which this term we have been using time and again. So we target the patient holistically. We try and control his hypertension. We try and assess what is his cardiovascular risk. We try and assess how much is his diabetes, for how long it has been there, whether it has caused any end organ damage, the diabetes itself. So these 3 things we generally look at. I won't really know what is your approach, but this is one which I find very practical and useful.
Absolutely, absolutely. My only thing is that I tell them my first 3 modalities of therapy is weight reduction, weight reduction, weight reduction. I think that is the central thing to all approaches to things. Everything else just is an add-on. And the simple thing is that whatever we do, I think 70 to 80% of all therapy that works is weight reduction and exercise. Everything else of drugs, etc., are only add-on therapies. There's a question about obesity and liver disease, we know. But can you be non-obese and still have liver disease? Parimal?
Yes, we do come across people who are not really very obese. Now, there's a question which I could see here. So he's written that he is a man who is reasonably fit, but he has a little central fat and he's having non-alcoholic fatty liver disease. So there is a concept of body mass index which tells us what is your level of overweight. And you can have people who are in the range of say 25 and 26 and they can have fatty liver. And this we term as what is called as lean NASH, or people who are thin and who can get NASH. So the spectrum is a little different. This is one exception to when we say that you have to lose weight. And this is one exception where their weight is already reasonably good, but still they have fatty liver. So this is one group where we don't tell them to lose weight. Well, I think a lot of these patients can be insulin resistant for various reasons. And other thing very important, for some other causes, rarer disorders, which can cause fatty liver, and we look more diligently in these patients for these other disorders. There are a lot of studies, in fact, from India, from West Bengal, which have looked at this problem. So you can say that India is a very leading country where this research initially started, and then it has been taken up all over the world as to try and find out why a person who is not fat gets fatty liver. I think you should also give your views on this and let us know as to how you go about treating these patients or evaluating these patients.
I don't know, funnily, we don't see too many lean NASH in our part of the country. I don't know, we don't see. But I guess they are there. It's not that they aren't there. But I agree with you. They can be challenging because weight reduction is not the major strategy. And perhaps there are internal factors which make their liver produce more fatty acids, free fatty acids, and sort of perpetuate a liver damage. And as you rightly said, insulin resistance may be a factor. Now, there's a question that has come up about someone says, how much weight should I lose? He says, I am 50 something and I've gone to 49, 54 to 49. So what are our targets of weight loss and how do they benefit?
So actually, when you tell the patient about weight loss, the first thing we do in practice is to check what is the patient's weight and height and check what is his BMI. So you can categorize these patients into overweight, obese, morbidly obese. then you start telling them that this is a problem and they need to lose weight. Like you said, lose weight 3 times, it is very important, because one of the most important things you have to remember is this really doesn't cost much. Losing weight, you have to do exercise. In fact, you have to probably cut down the costly items in your diet, such as fats and sugars and ice creams and everything. But having said that, coming to your question precisely, any weight loss is better than none. That's the first statement I would like to make. Once your weight loss starts going above, say, around 5%, then all these inflammatory cells which we were talking about, they tend to disappear from the liver. If you are able to do a weight loss of about 7%, then you can have considerable resolution of NASH or non-alcoholic steatohepatitis. And if you lose more than 10%, even the fibrosis can go off. So it is a kind of grading. So if suppose somebody is, say, around 90 kgs, to tell him that you should come to 70 looking at your age is not a very realistic proposition. But even if he says comes from 90 to, say, 80 or 78, I think you can almost certainly say that most of these patients, if they achieve this and maintain it, of course, that's also very important, then they can have a resolution of fibrosis. So if their fibrosis scan to start with was, say, around F3 or something like that, you have the patient lose weight with motivation, and then you find that after that his fibrosis scan is practically normal. So I think that is something which is a very novel finding which you get in practice. And like I said, very important, motivation is the main thing, and persisting with the weight loss is very important.
From motivation to motivation.
Yeah.
Okay, so the simple message is target at least 10% of weight loss. If you get between 5 and 10, you're still there, not bad. But less than 5, maybe not enough. Now, to put it in practical terms, Parimal, how do you counsel, how do you make them lose weight? Is it all exercise? Is it diet? How much is diet? And how do you target this thing? I think a lot of patients would be quite happy to know what is your mantra.
The thing is, you ask them to focus on various types of exercises. There is a question from someone as to, this is COVID era and I want to lose weight, and how can I lose weight? So it is not necessary that everybody has to go to an expensive gym to lose weight. So you can do various types of aerobic exercises at home and you can lose weight. So I think one thing which we try and tell patients is aerobic exercise is important. So we try and encourage them to do that on a regular basis. If you look at the recommendations from a scientific angle, say about 20 to 30 minutes of reasonably vigorous exercise, which includes walking, cycling, doing swimming. So you can do treadmill also. About 20 minutes, 5 on 7, 5 days out of 7. So you do this very regularly. Now, many times people say, I have been walking for the last 15 years, but there is no change in my weight. So what I generally tell them that when you mean, what I mean by fast walking is, suppose you are walking and there is a phone call, the person on the other side should ask you, why are you sounding so breathless? So that means you are really walking fast. So if he does something like that very regularly, then I think the weight loss. So it is not only exercise, it has to go with diet as well. So I think since I have spoken about it, you can shed some light on what is, I'll ask you, what is your mantra of diet for these patients?
I believe that weight loss can be achieved largely through diet, and there is an exercise component also to it, which you have lightly alluded to. At the beginning, I would say that there is good news for those of us who don't believe in very vigorous exercise, that there is no difference in the benefit within very strenuous exercise and moderate exercise. Moderate exercise is good enough. That is, walking 30 minutes every day, brisk walk, 5 days a week, is as good as doing very sort of aggressive exercise on a treadmill or things like that. If you can do it, great. But if you can't, not a bad idea. But it's important to have a good diet plan. And what I do is I first target a weight loss of, suppose his target weight loss for that patient is 8 kgs. I say, I want you to lose between 4 to 5 kgs in the next 6 months, which is not difficult to achieve because first 2-3 kgs are very rapidly you can lose that weight. And that is with a diet plan. And I actually specify. I go down to as less as 1100 and 1200 calorie diets. And unfortunately, I meet with a lot of resistance from dietitians. Dietitians who don't sit in hospitals never understand this business about low calorie diet. They think every guy who goes to work should have an 1800 calorie diet. So it's very important to come down to these 1100 and 1200 calorie diets for it to make a difference. The second is, of course, as you said, cut down your carbohydrates, all those sweets and fats, all those sugary drinks, fats, maybe turn into a more vegetarian diet. All these help. So diet with sufficiently low calories. 2 is modest amount of exercise and give them a period of time to achieve it. If you say that you must lose it in 3 months, he's not going to be motivated. He won't, and he'll give up. And you have to keep reinforcing that every time he comes back, say, okay, good. You've lost 2 kgs. Great job. Let's see how you can lose 2 more. I think that's the way I go.
So, Naresh, you must have wondered where I suddenly disappeared in between. So I just went to have this because we have had about half an hour. So I thought I'll have a cup of coffee now. And that's what I'm having. Yeah. So I think that I read a lot of papers starting from this hepatology paper saying that you should drink coffee for non-alcoholic fatty liver disease. Now I come from Pune and you come from Bangalore, Karnataka, which is like Nilgiri, and the coffee is right there in Karnataka. So what is your take on, should I be having this cup of coffee now or shouldn't I have?
Great. You should be having the coffee and not just one, maybe up to 3 cups a day at least. Okay. Because coffee is shown to be beneficial to the liver. But I guess other antioxidants, even green tea is beneficial to the liver.
But so should I add sugar to this?
Oh, certainly not. We're trying to cut down your calories.
Okay.
So certainly no sugar. Just maybe black coffee or coffee with a little milk is just as good. So while you sip your coffee, let me ask you, what are the benefits about these various other diets that are, sort of flouted on the net and otherwise? Do you believe in any specific diet or whatever your mummy cooks is good enough?
So actually, if you look at our Indian diet, I must admit that it varies from the region to region where you're talking about, but it is overall a carbohydrate predominant diet and relatively low on fat and okay on protein. So there are various types of diets which have been proposed. So you can have a keto diet or you can have an Atkins diet. So these are very high fat diets which people recommend. Then you can have a paleo diet, which is a little more on proteins. You can have a Mediterranean diet. So if you actually ask me amongst these, and if you tell me that you have to tell the patient that you have one type of diet, then I think the Mediterranean diet is the one which probably goes the best with this concept of non-alcoholic fatty liver disease. And this, of course, anybody can check on the net and see what components are there. But to highlight in brief, I think a lot of fresh fruits, which are colored because they have antioxidant properties, a lot of green vegetables, a lot of legumes and nuts, and good amount of protein coming from milk and various cereals and pulses. So this is what is very often seen in a Mediterranean diet. It is needless to say very tasty also if you prepare it well. And the other addition which is there in this diet is olive oil. So olive oil is supposed to be a very good thing for fatty liver disease for various reasons. And of course, it is very expensive. I think I just checked with my wife yesterday and she said it's about 3 or 4 times more expensive than the oils which we get. But olive oil is something which is there as an addition to the Mediterranean.
But Parimal, the olive oil that is used in Mediterranean things is just used as it is. It's not heated and, not like our masalas.
It is like a topic.
So the benefits of olive oil are just to be added on. It's you can't substitute it for
very true.
Indian
That's a very
cooking.
important point. Yeah.
So what is the Indian oil that you prefer? Is there any such thing for cooking it is better than something else?
See, my way of remembering it is OMG. So olive oil, mustard oil, and groundnut oil. These are reasonably good oils. And canola oil, if you have it available. These four, I think, are fairly good oils to take.
So it's, oh my God. OMG.
Yes.
Okay.
And
that really helps.
Another thing which I would like to add here is all these fats which become solidified at room temperature, like butter, cream, which comes on the milk after you heat it. Then you can have all things which become solidified. Ghee, margarine, dalda, all these things. So this is again not anything against the brand, but these are all not very good fats for your body. So everything which does not get solidified is better, and amongst them, these 3 or 4 which I mentioned are even better.
Okay, there are a lot of questions on diet and weight. Someone says I'm 55, I'm 96 kgs and I'm 5 feet 5 inches, and I have fatty liver. I take vitamin E. What should I take in my food to lose weight? I think we've discussed a lot of these issues. For a person who's 5 feet 5, I think
BMI will be very high.
Yeah, you're about certainly almost about 25 kgs overweight, and so you have a long way to go. Just a very provocative question. Do you believe in bariatric surgery for NASH?
It is not a recommendation actually for practically most of the patients with NASH. So what we do in practice is, suppose somebody is there with a BMI of more than 40, 100% he has to have bariatric surgery. If it is say more than 35 to 40, you look at comorbidities and various things and his fitness for the surgery, and then recommend for surgery. In 30 to 35, very often these patients have diabetes. And now there's a new twist to the story of bariatric surgery. So it is also called as metabolic surgery. So our diabetologists and endocrine friends, they have really found that this can be useful in that group of 30 to 35 if the sugars are not getting controlled with anything else. So that, of course, you have to do in consultation with your diabetologist. And
I have many young women.
But for 25 to 30 or 30 to 35 also, for that matter, 25 to 30 definitely no surgery.
I have a lot of young women who have fatty livers and who have been advised liposuction by some surgical colleagues. So what's your take on that?
Well, I think
they're removing the fat. So
yeah, it is more of a cosmetic surgery, so it is good for cosmetic purpose. But I think they have to do an overall lifestyle correction and weight reduction. And also for this gentleman who is pointed out that he is 5.5 and weight is 96 and he is taking vitamin E. So I think the focus has to be, like we have been impressing, it has to be mainly on weight loss and diet rather than taking a vitamin E and then continuing your lifestyle.
There's one provocative question someone asked, is wine good for fatty liver? Is wine good for fatty liver? So
this, I think, I would actually take the liberty of quoting our friend, Dr. Tyagi, whom I heard saying this, that, see, every patient with fatty liver, it is non-alcoholic fatty liver disease, and they will always ask for some concessions or some discounts on their alcohol intake. So first thing is, I tell them no concessions and no discounts on your alcohol intake. You're not supposed to take it. So it is like, a can which has petrol filled in it. Whether you put one matchstick which is lit or 2 or 3, the end result is going to be the same. So no alcohol for any patient with fatty liver disease. Having said that, there are safe limits of drinking, but this is not for people who have already had their hepatocytes ballooned with fat, because you are going to just add insult to injury by doing that. So my take on it is no alcohol. Because once you say that the patient can have a little alcohol, and you often find that the wife is sitting by the patient's side and she is gesturing to you this way that you tell him not to take alcohol. So I think she is the wiser person and she goes by what we would also say. So we tell the patient no alcohol.
There are some questions, Parimal, about the relative benefits of exercise vis-a-vis weight loss. And I'd like to reiterate that weight loss is the most important. Exercise is only a small component. Exercise, if you do, is unless you achieve weight loss, is virtually of no benefit. So it is important that you focus on weight loss and some amount of exercise. And I said earlier, the exercise does not have to be vigorous. Someone has asked a question is, I'm an elderly person, what kind of exercise can you do? Simple walking for 30 minutes, a brisk walk, is good exercise. You don't have to run, don't have to go onto the treadmill and injure your knees and things like that. That's not necessary. So without a doubt, weight reduction is the central to this whole key of thing. Now, the next issue is about easy exercises, weight reduction, best diet. We have discussed a lot of these questions. Lean NASH, we have discussed. Question is, does fasting, there are patients of mine who eat once a day to lose weight. Is that a good idea, Parimal?
Yeah, of late, I think, see, if you look at these various diets, they vary on various parameters. So the first one which I discussed was like the Atkins diet, and they mainly vary on the components of the diet. They have little to say about when you should have them. By and large, they recommend four meals or 4 feeds a day. Then there are diets which may not have too much on the component of the diet, but the frequency of the intake. So this question pertains to the second group of diets, where it is called as intermittent fasting. So intermittent fasting is a thing which has come up of late, and it is very popular. What it basically actually does is ultimately to cut down on your calories indirectly, and also each time you take a meal, there's an insulin surge, and insulin is an anabolic hormone, so it will put all the things as storage in the body. And this keeps on happening time and again, especially in people who are snacking time and again. So this is something which gets prevented by this diet, and it is beneficial for patients. One has to be careful as to who follows this diet. So if you have a patient who has a peptic ulcer with a complication, so it has to be done with medical advice, and the patient should check that he's fit to have that diet. Because if a wrong person takes it, he can have harm from it.
Okay, 2 issues that have come up on the questions, Parimal. One is that they say young people don't like to exercise, don't like to diet. So is there a role for certain drugs to cut down their weight? You believe that that's a good therapeutic strategy?
Drugs per se, actually, if you look at the proper scientific recommendation, they are recommended only for 30 to 35 BMI when diet, exercise are not working. So again, I think I would concur with your views that they have to do diet and exercise. There are medicines which are there for losing weight, like you can have Orlistat, you can have, you had a drug called as Rimonabant for losing weight. You can have some drugs like topiramate, which are used for other purposes, but people tend to lose weight with them, and they are recommended for losing weight. But they are not really the answer for these patients. We have to emphasize that you are a young man, you are fit to do any exercise. Look at yourself in the mirror. You look at some people who have great physiques in the mirror and try and emulate them and go to that stage. That is what I would tell them.
The other issue is about a lot of intake of fruit juices. We now know that it's a kind of an very prevalent, at least in many parts of the West, is that everyone takes in a couple of liters of fruit juice, which contains a lot of sugar. Is this an important cause for fatty liver?
It is actually. So these fruits actually contain sugar, which is called as fructose. So fructose is a sugar which, if you look at glucose and what happens to glucose in the liver, glucose gets converted to what is called as glycogen, which is a storage form of glucose. And when you're fasting, this gets utilized. So in intermittent fasting, this is what happens actually. Your glycogen stores get depleted slowly. With fructose, what happens is instead of getting converted to glycogen, it can get converted to fat. So these fruits and fruit juices They are sweetened. They inherently cause fructose. They inherently contain fructose, and they have a sweetener called as fructose corn syrup. So this is something which is added, and this leads to tremendous amount of fat accumulation in the liver. The difference between eating fructose in a fruit and in juices is that fruits, there is associated fiber in the fruit. So the absorption is very slow. While if you take it in a juice with fructose corn syrup or with sugar, you suddenly have a big load of sugar in the body or fructose, and you can have a big amount of that fructose going into fat. You can have a big surge of insulin that will again lead to generation of fat and various things. And then your fatty liver will worsen. So it is not recommended.
Let's go back onto, we've answered a lot of these questions. Let's go back onto fatty liver. And in the beginning, I said that the more ingredients we have in the pot, the likely that the outcome is going to be inflammable, as you put it. So if you have someone who is overweight or obese, who's got diabetes, whose cholesterol, triglycerides are high, who's got uncontrolled diabetes, does not exercise, very sedentary kind of lifestyle, he's asking for trouble. And these are the kind of patients who silently progress. And this is something that I want the audience to understand, is that this progression can be silent, and we suddenly see them at a stage when they have serious liver disease. And that is why when you have any of these conditions, I think during your health checks, I think it's important not only to see how big your liver is, what the liver tests are, what is the ultrasound showing of the liver, so that you intervene. And the word that I liked that you use, the window of opportunity should not be lost. So that brings us now to the next issue is, do we have options in medicines? I mean, not to reduce weight, but to decrease the fat in the liver, to decrease the fibrosis or stiffness that's occurring in the liver. Do we have drugs, and how useful are they?
Yeah, I think there's tremendous research which is going on this field, because many times you have patients coming to you and they say that, doctor, it's a very common condition, but there is no drug for so many years. So it is not the case. There's tremendous research going on this. And there are many drugs. The one which I think somebody has mentioned earlier is vitamin E. So that is very commonly used for these patients. We won't go into the mechanisms of actions of these drugs, but that is supposed to be very beneficial. There are certain groups of patients.
But not in diabetics. We don't use it in diabetics.
Yeah, very true. I was just about to say that not every patient should be taking vitamin E. So there are recommendations, guidelines for whom you should use this. The other drug which is very commonly used is metformin. So metformin is a drug which diabetics use very commonly. It can act as a double benefit. So it can not only benefit their diabetes, but also their fatty liver. Then there are some very newer drugs. So there is a whole new concept of what is called as nuclear receptors. So for anything to act in our body, it has to connect to some receptor, either on the surface of the cell or inside the nucleus. Then it has to go inside that and tell the machinery inside as to what is supposed to be done. So there are a lot of new drugs. There are some which are called as obeticholic acid. There are some which are called as saroglitazar, and so many others which are coming up. There are good trials on this. They have shown that if you use this drug for 6 months to 2 years, you can have reversal of fibrosis. So there definitely is a good number of drugs. Keeping the diabetes in control, needless to say, works in most of these patients. So that also is very important. And other thing you have to remember is that a lot of these diabetic drugs, they have a beneficial effect on the liver, which is beyond just sugar control. So if you look at these SGLT2 inhibitors or various other drugs, liraglutide, they can have a beneficial effect on the liver, which goes beyond just the glucose controlling capacities. So you have a lot of drugs, and a lot of drugs are coming up. And I always tell patients that these drugs are expensive things to use in the long run. And again, something which can be controlled without losing anything from your pocket is doing exercise and diet. And do that before going to drugs and saying that it is like a person who takes alcohol and he says, doctor, I have been taking Live 52 and I have been taking alcohol. So can I continue it? So it is something very similar. So do your exercise, and if you have failed in that, or if for some reason it is not achieved, you can definitely select a lot of these patients for various drugs. They are definitely beneficial when properly used with proper medical advice.
There are another two messages that I think our listeners need to go back with this, apart from knowing that, there are options for fatty liver, there's a window of opportunity and what you can do, is that a lot of these patients may not see a gastroenterologist ever. They may be sitting with their diabetologist or cardiologist treating their hypertension or their cholesterol or sugars and so on and so forth. I think it's the message to them that they must speak to their physicians that, yes, I've heard about fatty liver. Do you think I could be having fatty liver? Do you think I can do something about it? And I'm sure when they do this proactively, I'm sure the physician will also get an opportunity to look at this dimension and intervene, maybe manage it himself or refer to someone appropriate and utilize this opportunity to reverse these changes in the liver rather than say, I've treated your blood pressure, I've treated your heart, but I'm sorry, your liver has gone for a 6.
So I think one of the importance of having all these days like World Environment Day and so on is this Fatty Liver Day, which is to highlight the importance not only to patients, but also to physicians and various people in the medical profession so that they're aware as well as hypertension and all the other comorbidities and treat the patient as a whole. There are a lot of alternative medications and alternative treatments which are supposed to be beneficial. So what is your take on that? Somebody has asked about homeopathy and there are
several things. There are questions on the gym instructor giving them some whey protein and things like that. I personally don't believe in that. I don't think those are great options. A lot of time they are mixed with something else, and so they may have more disastrous consequences. So my policy is a strict no to anything other than what we clearly know about. Even those that we know about, we know that they have come with, the whole package comes with a lot of negatives. So I think what we need to do is the minimum medication and utilize it appropriately.
Definitely.
So these alternative powders, someone has even asked a question about the role of curcumin or haldi or turmeric powder in treatment. Do you think there is any proven benefit or there is just a passing fad?
It is something which may have potential benefits, definitely not harmful, could be tried. In some other gastrointestinal disorders like inflammatory bowel disease, we have seen people benefiting from it. But maybe with more research, it may come into day-to-day clinical practice.
But the evidence, at least scientific evidence for it, is still lacking.
Not there.
And the amount of haldi that you need to take is
huge
chunks
large.
of thing. Yeah.
Yes.
Not a pinch of salt, but a mountain of haldi. So, is increased cholesterol something to do with fatty liver?
Yeah, it definitely has to do, but you have to look at two components. One is the LDL cholesterol and the second is the triglycerides. So many times people come and say that I have cholesterol. So basically it is the LDL cholesterol you have to look at very carefully, and very importantly also the triglycerides. And then you have to remember that very often drug which acts on one does not act on the other. So you have to give medications which will bring down both of them with proper advice. I think that is what I would say on this.
So treatment of this dyslipidemia or increased cholesterol, triglycerides is an important aspect of things. And drugs like saroglitazar do that as well in diabetics.
Triglycerides do come down very well with this drug.
There are two questions that have come, and one of them is, I thought really the question of the day is, what are the initial symptoms of NASH? And someone says, I have a lot of tiredness, a lot of fatigue. Can that be part of NASH?
Yeah, I think I must say that we did not speak much about symptoms of non-alcoholic fatty liver disease. We spoke about an incidental ultrasound or incidental abnormal liver function test. But 2 or 3 symptoms which I think are important. One of them is, of course, fatigue. End of the day fatigue is very common in these people who have non-alcoholic fatty liver disease. The second thing is pain in the right hypochondrium, as we say. So below the
just
right
below
rib,
the ribs on the right
there
side.
can be a dragging kind of sensation. So these are pretty common symptoms which people present with. Very often, actually, what happens is the patient does not feel that these are very important symptoms, or they may just get brushed aside as excessive work which the patient has been doing, but they can definitely be a harbinger of something lurking inside your body.
There's one point again that I'd like to sort of bring to the audience is all of them say I've done my fasting sugar and it's quite normal. But I think we must get not only just a fasting blood sugar, but one after 2 hours of glucose. And we find that about 20% of diabetics get missed only because we do just a fasting blood sugar. So if you do a post-glucose blood sugar, we find that we pick up more diabetics who actually are having fatty livers because they go undetected. Remember that diabetes is diagnosed almost 7 years later than it actually started. And for that, we need to emphasize that we need to do the proper tests. The other question, Parimal, is this disease only of adults? Do we see NAFLD or fatty livers in children?
Yeah, definitely we see this in children. I'm not much into pediatric practice, but we see it very commonly in children. Our pediatrician friends do see a lot of people. There is a term which people don't like to be alluded to by, that is a couch potato. These are children actually who are not exercising, they are watching TV, they are having snacks. So these are children at extremely high risk for non-alcoholic fatty liver disease. And it is a very important problem. Like we said, if you have an adult who starts at 30 with a fatty liver and goes on very slowly over next 15 to 20 years, his age is going to be around 50 at that time when he will have problems with it. If you have a child which starts with a fatty liver at, say, the age of 10 or 12, by 30 or 35, especially if unfortunately he or she develops some other comorbidities, he can really be in a very bad shape. So childhood obesity and childhood fatty liver disease, they are very important things to be looked at.
So the contributors are childhood obesity, sedentary lifestyle,
very true,
junk food, lot of fruit juices, and very anxious parents say, "Doctor, I want my child to be healthy, doctor." That kind of attitude certainly may not be good. And that's actually putting the seed of adult diseases. You're starting putting the seed in childhood. And so when they are young adults in their 20s and 30s, we see them coming with cardiovascular problems and so on. So the diabetes that would in our forefathers, we would see later in life, now we are beginning to see it in the 30s. So I think this is, part of the childhood obesity. And I see a lot of children, you ask them, do you play football? Yes, doctor, I play football. He's playing with his increased screen time, 2 hours on the TV, 2 hours on the PlayStation. So I think those are things that we must really address very seriously if we have to handle this epidemic of NASH.
So I think we are talking about the COVID pandemic, Naresh. But don't you feel that this NAFLD or NASH also is a pandemic by itself?
It's a bigger issue. If you ask me, there are going to be more deaths, because of NASH than COVID. And people have asked, what can I do? I can't exercise during COVID. Nothing is going to happen. You can wait for 2 months. Your exercise program, all what you do is going to be long-term. If you were to wait for 2 months and then start it religiously after that, you're not going to lose anything. You don't have to start jumping in your 1-bedroom flat and start getting anxious. Eat sensibly and start exercising once the lockdown opens out. Like we're better off in Bangalore than you're in Pune, but I'm sure things will get better soon.
Very true.
Are there any other pressing questions? Would you like to again emphasize this lean NASH? I know there are a lot of questions coming out on lean NASH. Can you just re-emphasize the thoughts on this?
Yeah, lean NASH, I think one thing which we definitely look at is insulin resistance. The second thing is somebody pointed out that the person overall looks slim, but he has a big stomach. So this is a very common thing which we find in India, where you find that the arms and the legs are relatively thin, but a slightly bigger stomach. So there can be a central obesity in all these patients. So when you mean lean NASH, the BMI may be okay, but you might find that the waist-hip ratio is not very correct. So you have more obesity around the stomach and visceral obesity, which is around the intestines. And these fats inside and around the intestines are not supposed to be very good fats. And they generate a lot of hormones which are bad, not only for your heart, but also for your liver and so many other organs. So this is how this lean NASH people actually tend to have various disorders, although they look very slim. Add to that, if there's no exercise, then of course it can be more trouble for the patient. Needless to say, weight loss is not very important, but you can have some changes in the diet so that you can have better oils like walnuts. You can have, like I said, we spoke a little about the good oils. So those can be increased in the diet. The saturated fats can be reduced. And overall, then you can follow up these patients. Do you feel that these patients have a better prognosis, worse prognosis, or
no, I
they are about similar to any NASH patient?
No, I think they do worse, because one big strategy of weight reduction is lost, and they seem to reach their problems much faster. I mean, that's subjective. I don't know. Is there objective studies to this? I don't know, but this is my impression. There are two issues that I want to bring up, and one of them is a question on asking, is hyperthyroidism associated with fatty liver? I think yes, there are several things apart from these triglycerides and body fat and obesity. There are a lot of endocrine diseases which can cause fatty livers. Actually, very rapid weight loss. If you're dieting and you lose weight very rapidly, or you have a bariatric procedure and lose weight rapidly, that can also cause weight loss. And that is why the weight loss has to be, managed appropriately. It cannot be very drastic. I think there are a lot of drugs that can cause a fatty liver as well. And I think it is important that we know these drugs and monitor the patients on these drugs, especially some of these cardiac drugs that they use, like amiodarone and things like that, can cause fatty liver. Some of the drugs they use for treatment in cancer. Yes, tamoxifen are known to. So we need to be aware of these, and that's a separate group by itself. So it's not necessarily all obesity and think there are other factors. All can cause a fatty liver. Someone very interesting, I think you're being very hard to get, Parimal. Someone says, how can I get an appointment with Dr. Parimal Lavati?
Is it really I don't think it is that difficult.
Okay, but I am sure they can see their physician or gastroenterologist in their towns or cities and get a good sort of advice for the thing. And this platform is always there to the NASH 24/7 platform. You can always come back to this platform to get your updates and facts clarified. Shall we then call it a day, Parimal? I think.
Yeah, I think if you ask me as to what are the messages you would like to give to the audience, and I'll ask the same to you later on. I think first thing is it's a silent killer. So having a fatty liver diagnosis, you take it as the first warning signal and don't get alarmed. Second is window of opportunity. That also is very long, unlike many other diseases. And two simple strategies, like Dr. Naresh said, weight loss and dieting, proper diet and correction of lifestyle. You can get over this problem without taking any medications to a big amount, and also looking at various comorbidities. You can get over this potentially silent killer and have a victory over this silent killer. And I can ask you reciprocally as to what is your message for the audience.
I think the important thing is that the killer may not be liver disease. The killer may be cardiovascular disease, a stroke or a heart attack, or even bad is cancer. Cancer is associated with obesity. So these are patients of this, are prone to this. And so that's the big message that comes out. So you intervene here, there are a lot of bonus benefits that you can get. I think with this note,
should we say that it is time to break for coffee and have our livers get more healthier in the next cup of coffee?
Yeah, absolutely.
Sure.
See you, Parimal. Thank you. And
Thank you very much. And thanks
to
the audience for participating and listening. Thank you very much.
Thank you. Bye-bye.